An upper endoscopy for chronic reflux symptoms performed on a 67-year-old woman revealed this GE junction adenocarcinoma, which on EUS proved to be unresectable. Over the next 6 weeks, she received chemoradiation therapy that included a divided dose regimen of 70 Gray of external beam radiation therapy. This video catalogs the evolution of radiation-induced esophagitis over the ensuing 13-month period. Nausea and odynophagia developed within 2 weeks. Her symptoms progressed despite PPI therapy, and at 6 weeks, EGD was performed and demonstrated this circumferential ulceration of the lower esophagus in the field of her radiation exposure. The ulceration is superficial, featureless, and non-hemorrhagic, but was associated with severe discomfort resulting in poor oral intake. Therefore, a PEG was placed at this time and she was continued on PPI therapy. Over the next 3 months, her nausea and odynophagia resolved, but she then developed progressive dysphagia. This EGD performed at 5 months following XRT demonstrates this 2 to 3 millimeter stenosis in the area that was previously ulcerated. The stricture at this early stage is soft and dilates easily. The scope can be passed through into the stomach without much resistance. The stenosis was dilated further to a luminal diameter of 12 millimeters, and the patient was continued on PPI therapy. The patient had a good therapeutic response from the dilation and returns at 7 months following XRT for inspection. The ulceration margin is now better defined, but the tissue is noticeably more fragile. At 9 months, she is able to tolerate full liquids and some soft solids. Her G-tube has been removed as her oral intake has improved. The ulcer, though smaller in dimension, appears slightly more excavated and is covered with a thick fibrin layer reflecting chronicity. Finally, at 13 months following XRT, her symptoms of dysphagia have entirely resolved and she is eating normally. EGD now shows the area to be almost fully reepithelialized. There are atrophic changes in the region of the GE junction, and radiation-induced neovascularization is now evident in the cardia. These changes are identical to those seen with radiation proctitis following XRT for prostate cancer. Radiation injury to the esophagus will occur in over half of the patients who receive 60 Gray or more of XRT in divided doses. Within 10 days of this radiation exposure, hyperemia and edema develop as a consequence of endothelial injury and subsequent increased vascular permeability. Ulceration is common. With sufficient radiation injury, accumulating collagen and granulation tissue lead to scar and stricture formation. Because of the rich blood supply to this area, radiation injury usually heals, but in this case, ulceration persisted for a year. Eventually, after 3 dilations, this area fully reepithelialized and the stricture stabilized. The time required for complete healing of radiation-induced esophageal injury is a function of the total radiation dose, the timeline of the dosing interval, and the health of the patient. Radiation-induced neovascularization remains in the region of the cardia. The patient, however, was able to resume a normal diet and at 16 months remained disease-free.